Hello, and welcome back to another episode of Age Better, where each week we take a deep dive into all the ways we can feel better, look better, live better, and, yep, age better. I'm your host, Barbara Hannah Grufferman. Today we're exploring a topic that could revolutionize how we assess and manage heart disease risk, particularly as we get older. For years, the traditional lipid panel, which measures LDL, cholesterol, and also HDL, has been the standard for evaluating heart health. But new research from UT Southwestern Medical Center suggests that this test might not tell the whole story. The study, recently published in JAMA Cardiology, reveals that a blood test for, I hope I say this right, apolipoprotein B, or commonly known as ApoB, may be a more accurate marker for assessing heart disease risk. This discovery could have significant implications for how we approach heart health, especially for those who might be at risk, but guess what? Don't even know it. So today we're honored to have with us the lead author of this groundbreaking study, Dr. Marie Navar. Dr. Navar is an associate professor of medicine and preventive cardiology at the University of Texas Southwestern Medical Center, where her research focuses on preventing heart disease, particularly through lowering cholesterol. She is also a member of the executive committee of the American Society of Preventive Cardiology and is recognized globally as a leading expert on cholesterol and heart disease prevention. She is an absolutely fantastic guest, and I thoroughly enjoyed this conversation. So, in this episode, Dr. Navar will share her insights on why ApoB testing might be essential for everyone, not just those with obvious risk factors, and how this could change the way we think about and manage heart disease risk. So, you know what to do. Pop in your earbuds, maybe take me out with you for a heart-healthy walk while you listen to this conversation and get ready to age better. Stay tuned.
My dad works in B2B marketing. He came by my school for career day and said he was a big ROAS man. Then he told everyone how much he loved calculating his return on ad spend. My friends still laugh at me to this day.
Not everyone gets B2B, but with LinkedIn, you'll be able to reach people who do. Get a $100 credit on your next ad campaign. Go to linkedin.com/results to claim your credit. That's linkedin.com/results. Terms and conditions apply. LinkedIn, the place to be.
How do you feel great on vacation? Like really good? Easy. You go to Aruba. You'll spend your time relaxing on cool white sand beaches and floating in healing blue water. You'll immerse yourself in natural wonder and find your center on an island where things move at your speed. You won't just feel great, you'll feel relaxed, renewed, and ready for life. That's the Aruba effect. Plan your trip at aruba.com.
Welcome to Age Better, Dr. Navar.
Thank you so much. I'm really excited to be here.
Oh, I'm so excited to have this conversation. This is really important information that I want the Age Better audience to know about. So, Dr. Navar, let's start here. Can you explain what is ApoB, as you call it, and how is it different from the cholesterol measurements typically included in a standard lipid panel when you go and get your annual physicals?
So ApoB is an abbreviation for a protein name called apolipoprotein B. So to explain it, I have to explain a little bit about how cholesterol particles float around in our body. So cholesterol doesn't just float around dissolved in our blood like sodium or potassium. It's actually packaged up in what look like little meatballs. And the meatballs have triglycerides and cholesterol in them. And there's one protein on the surface of that meatball, and that protein is called ApoB. So we have these little lipoproteins or packets of cholesterol that float around in our body. There's the good cholesterol, which is HDL cholesterol, and those HDL particles are the particles that are transporting cholesterol from our tissues back to our liver to be excreted through our gut and kind of lower the cholesterol in our body and in our tissues. And then the bad cholesterol packets are the lipoproteins that are taking cholesterol, and those are what get trapped in our arteries and cause heart attacks, and heart disease and stroke. So when we measure cholesterol using a traditional lipid panel, what we're actually doing is weighing the amount of cholesterol in those particles. So the LDL-C, what you're used to seeing as bad cholesterol, is the weight of cholesterol in LDL particles. But it doesn't actually tell us how many of those particles are floating around. To do that, we have to measure what's called the ApoB. And the ApoB is a count of the number of particles of LDL, VLDL, and IDL, which are all the three types of bad cholesterol particles that we have in our body. And then, if you'll pardon a little bit more science on this, the reason why it's relevant is that it turns out that how much your cholesterol weighs doesn't tell us exactly how many particles you have. So you could have particles that are really cholesterol enriched and have a lot of cholesterol per particle and look like you have a high LDL cholesterol. But if your ApoB is low, you're actually being falsely worried about your cholesterol level, because what matters more is the number of particles you have, not how much the cholesterol weighs. And then on the flip side, you could have what looks like a normal LDL level, but a high ApoB, and you're at much higher risk than you might think based on just measuring the LDL on a traditional lipid panel.
So why is ApoB considered a more accurate marker for cholesterol-related heart disease risks?
So we've studied it a couple of different ways, but the best studies that sort of compare which one is better in terms of accuracy basically are studies that follow people for long periods of time, and they measure their cholesterol different ways. And they look to see which of those different measures is best correlated with whether or not they develop cardiovascular disease. And when we compare epidemiologically, how much risk is explained by LDL-C, or the weight of LDL cholesterol, versus ApoB, the number of bad particles, ApoB wins out almost every single time. And the reason for that is twofold. One is it's really probably the number of particles that matters, not how much they weigh. And two, LDL only measures that one type of particle, but there's other types of dangerous cholesterol particles that are totally missed, like IDL particles and VLDL particles. And ApoB is a really nice sort of sum composite of all of those in one single measurement.
So your study, and this is how I first discovered you. I am a bit of a medical nerd, and I like to read all of the medical journals. And so one of the emails I received recently was about your new study, and it highlights the concept of discordance between LDL-C and ApoB levels. What does this mean, and how common is this among people in midlife?
So the discordance is sort of what I was talking about earlier, where how much your LDL weighs doesn't actually tell us very well how many particles you have. So for most people, LDL is good enough. If you have a lot of LDL cholesterol, you're going to have a lot of ApoB particles. Or if you have a little bit of LDL cholesterol, you're going to have a low number of particles. But there's some people who that's not the case, and we're either over or underestimating their risk looking at just LDL-C alone. There's no magical cutoff for what we count as discordant. It really depends on your other risk factors and what your goal cholesterol might be. So I can't tell you how many people there are with discordance, but I can tell you that we weren't able to find a group that didn't have some degree of discordance. So we couldn't tell you based on who you are or what medical problems you have, whether or not your LDL and ApoB will track together, or whether or not they'll be discordant in one direction or the other.
Mm-hmm. And the study also found that even metabolically healthy individuals could have higher than expected ApoB levels. And so how significant is this finding for those who may be, as you were saying, otherwise low risk, at least on paper?
First of all, I don't want to miss the forest for the trees here. The biggest problem we have in cholesterol measurement is that people don't get it measured in any way, shape, or form. We recommend a traditional lipid panel at least every 5 years in adulthood, and more often if you have a change in your weight, your hormonal status. So women who are going through menopause should absolutely get their lipids updated, or if you get new diseases like diabetes or heart disease. So the bigger issue we have isn't which test, but it's that a lot of people never get it checked at all. Now, that being said, I think that if you're going through the trouble of getting your cholesterol measured, it makes sense to get a full picture of the risk. Because let's say you have heart disease and your doctor has said that they want your LDL cholesterol less than 70. You may be feeling really good if your LDL 65. But if your ApoB is 80 or 90, you actually have a lot of residual risk that we are missing based on just looking at the LDL cholesterol. So in my clinic, I measure both the LDL and the ApoB regularly to make sure I have both where I want them.
What is considered a reasonable number, like a good number to have for ApoB, or does it depend upon the person?
Totally depends upon the person. I can give you some ranges. So what I do in my clinical practice in people who have had heart attacks or strokes or at really high risk of having a heart attack or stroke, I usually want their LDL cholesterol and their ApoB certainly less than 70, but ideally less than 55. And people who are at sort of the intermediate risk, it usually target about 70. And then in the rest of the population, I try to target an LDL cholesterol less than 100. And a corresponding ApoB at that range is also about 100. So the numbers, at least once you're on treatment, tend to track pretty close together in terms of what ApoB you want to target. For LDL and ApoB, the number actually conveniently is the same. So it would depend on what your goal is based on all of your other risk factors.
And you mentioned menopause before. I mean, a big part of the age better audience are in menopause or are postmenopausal. So does that number have, based on your research, does that number change based on whether you're postmenopausal or not, like have gone through drops in estrogen? Does that impact it?
You know, I hate to add to the audience's disappointment because as if we don't have enough bad things that come along with menopause in terms of symptoms and other health
We do talk
changes.
about it a lot, yes.
But to add to the reasons why we need a refund on this is that generally we do see cholesterol levels go up during menopause. And some of that is hormonal, and some of it is also related to other changes in our bodies, often weight and diet and exercise change around that time for other reasons as well.
Right. So currently, as you referenced, the ApoB level testing it's not widely recommended, which is really insane to me that as I read your study and now I'm hearing you speak about it. So based on your findings and your research, what changes would you like to see in clinical guidelines, especially for people in midlife?
I want to be generous and defend the prior guideline writers. There's a difference in the guidelines saying you should test it versus not recommending it, but recommending against it. So the guidelines don't say not to check ApoB, but they've really stuck with the minimum testing and what testing has been used to guide clinical trials. So clinical trials for the therapies we use have generally looked at LDL cholesterol, and that's why the guidelines focus on LDL. But epidemiologically, the data are pretty convincing for ApoB. So if I were writing the guidelines purely by myself, and I'll say the way that I practice is I measure ApoB. Often instead of LDL, I think it's better for a couple of reasons. It isn't affected by fasting at all. So you don't have to be fasting to get it checked. And there's a lot less measurement error with it. So it turns out when we measure LDL cholesterol, we're actually kind of guessing. It's an equation, but we're estimating it based on the other parameters. And so there's a lot of noise in LDL levels. And some people on certain treatments may even get results that look crazy, like an LDL of 0. That's not real. It's just a problem with how we measure it. And we don't see that with ApoB.
Interesting. And so how might incorporating ApoB testing into routine care change the way doctors manage patients and maybe even treat them, especially those with seemingly normal LDL numbers, but have elevated ApoB? And also, I'd like to talk about treatment too, while we're on this. Statins, is that what one would go to treat this, to lower?
So for most people with high ApoBs, they also have high LDL. So most people actually aren't going to have a change in their recommendations based on ApoB or LDL. There are a few individuals that do. And I think I don't want to miss those individuals in clinical practice, which is why I test everybody for it. But in the vast majority of people, your recommendation is going to be the same with LDL or ApoB. Statins are absolutely the first line medication for lowering cholesterol and lowering ApoB. They are generic, so you can get them for less than $5 a month. We've had them around for decades, so we know exactly how safe they are, and we know how effective they are. And just to sort of give the listeners a little bit of context here, we think that for about every 38 or 40 points we drop your LDL cholesterol, we lower your risk of a major vascular event like a heart attack or stroke by 25%. So if you're starting at an LDL of 160 and you get down to 80, we've probably cut your risk of heart attack, stroke, big cardiovascular events down in half. And there is no other therapy that we have in prevention that is as effective as that. So that's where we start. We have a lot of other options after that, but statins are our first line therapy, the ones that we have the most data to support their safety and their effectiveness.
Mm-hmm. I had a medical expert on, a cardiologist, a few months ago talking about statins, and she's pro-statin, as many cardiologists are. I myself started a statin this year because my cholesterol level, while borderline, my HDL was really, really great. Like my ratio was excellent, could not be better. Low LDL, high HDL, but the total was getting up there. And again, I'm postmenopausal, so I'm a runner, so I am rather fit. I eat well. So all of my lifestyle choices really are helping that. But it was just naturally going up. And the statin has really helped dramatically, which is really wonderful. So I'm pro-statin as well.
I'll comment on a couple of things that I think are important for your audience to hear on this vein. The first is that diet and exercise are really important for heart disease prevention in general, but they don't do a lot for our cholesterol. So probably 90% of our cholesterol levels are determined, of our LDL levels are determined by our genes and how much our liver is making, and not by what we're eating or exercising. So for anybody out there that's doctor says that they should be on a statin, it's not a failure of your lifestyle. It's expected because a lot of it is encoded in our genes, and it has to do with how much LDL cholesterol our liver is synthesizing. The other thing I'll mention is that we have this sort of holdover from the past around the idea of a ratio. And this is especially important for women who tend to have high HDLs. And so our ratios look better because if our LDL is high, but our HDL is high, our ratio is lower. Turns out having a high HDL is good for you, but it doesn't offset the risk of a high LDL. That's like saying I'm eating a chocolate bar and a carrot and they're canceling each other out. It just doesn't work that way with cholesterol. So unfortunately, though, a lot of women have been told over the years that they don't need to get on LDL lowering therapy because their HDL is good. And that's just not true. So anybody out there that's been told that in the past, erase it and really think about these things as separate. If your LDL cholesterol is high, especially if you have other risk factors, you should be on treatment regardless of what your HDL is.
Oh, that's a really good point. And thank you for bringing that up. And again, I mentioned my own ratio that really was good. And my LDL is low. However, I have never had the ApoB test. It's just never happened. And so I mentioned to you before we started recording that I am getting my annual physical in September. And so I will be sure to get this test just to check because I love testing myself. I mean, I wear my Apple Watch. I test every single thing that is possible to test. So I'll be very, very eager to hear what that number is. Okay. So for the age better audience, what steps should they take to ensure that they're getting the most accurate assessment of their risk, their own personal risk of heart disease when they go into their doctor's office? Should they be demanding this test like I will be?
Well, I think the first and most important thing is seeking regular primary care. Good primary care doctors are tip of the spear for cardiovascular prevention. And that includes measuring your blood pressure, checking your cholesterol. If you have risk factors, screening for diabetes, talking about smoking cessation. If you're a tobacco user, there's a lot that we can do way beyond cholesterol. And if everybody did those basic things, ApoB would just be sort of icing on the cake. But if you're going to get your cholesterol drawn, asking for the ApoB, it's one more click for the doctor. And it's a way to sort of round out your overall risk assessment. The other test that I would recommend from a blood test standpoint is a lipoprotein A level. So this is a different kind of cholesterol particle. It looks like an LDL particle, but it has an extra protein on it called ApoA. And this type of particle is not picked up by the traditional lipid panel. And so if it's high, you won't know it if you've just had your cholesterol tested normally. LPA is a contributor to premature cardiovascular disease. And right now our guidelines recommend having it checked if you have a family history of premature heart disease. So a first degree relative with a heart attack or stroke before the age of 65 for a woman or 55 for a man.
Mm-hmm.
But I've been checking it more regularly in all of my patients because we have therapies that are being developed now that can help lower it. And I think it'll be important to know whose LPAs are high and they may be eligible for the therapy.
Mm-hmm.
But also, if somebody's LPA is high, and more aggressive at lowering their LDL, because while we don't have treatments for LPA, we can kind of offset that risk with LDL lowering. Now, that's not a test you need more than once. It's a genetically determined factor, and it's very stable over your lifetime. So if it's normal, you're off the hook and you don't need it checked again. But in terms of blood tests to round out your risk, I think an LPA is a good addition if you've never had one checked.
That's great. And I've actually seen some social media posts by the American Heart Association in the last few months talking about that test. Everyone, I will have in the show notes some more information about that test as well. For those of you listening in who have been following me and listening to the show for a while, you know that I have been talking about this other test. It's called the coronary artery calcium score test. And the reason I started talking about it was because last year I had on the show a guest she's a journalist, who was talking about her best friend, a runner, totally fit woman, postmenopausal, no issues that they knew of whatsoever. And she died of a massive heart attack. And it was only after that they discovered that she had calcium buildup in her arteries, plaque buildup. And then my guest went on to talk about this test, the CAC test, coronary artery calcium score test. That's an easy, inexpensive, non-invasive, so quick test. I mean, literally took me 8 minutes to do. In my case, my insurance didn't cover it, but very often it does. But even if it doesn't, it was inexpensive. It was about $120, well worth it. I found out my level is really okay. It was higher than I expected, though. Dr. Navar, it was 18, I was expecting 0, but it was 18. So anyway, I'll share that with you. But okay, everybody was shocked about this. I was shocked when I heard this because I thought I was really up on all of this medical stuff as it relates to midlife life. And so I have been encouraging people. So tell us more about the CAC test from your perspective. And what should women do if their score is high? And what do you consider to be high in midlife?
Well, these are just great questions. So as a preventive cardiologist, I love, and I use the term CAC, meaning CAC. So I say I love the CAC score because what it does is, when we're looking at your blood pressure and your lipids and all of these other things, we're sort of trying to guess your risk of having a heart attack or stroke. But heart attacks and strokes are caused by buildup of cholesterol in your artery walls that breaks off and a blood clot forms. And that's a heart attack if it happens in the brain. And if it in the heart. And if it happens in the brain, it's a stroke. The CAC score takes us one step closer to seeing if you're on the path to that by looking for evidence that you've already started to deposit cholesterol in your artery walls. Now, it turns out it's not the calcium that's the problem. But when cholesterol has been in the arteries long enough, your body's reaction to it is to calcify it. So if we could cut open a coronary artery that has atherosclerosis, we'll see a lot of cholesterol, but we'll also see little specks of calcium there. So those specks of calcium are sort of like the tip of the iceberg, and they tell us that there's probably a lot of other soft plaque or non-calcified plaque around. And it's that non-calcified plaque that can break off and cause a heart attack and stroke. Now, I love the test, particularly in people who are sort of on the fence about what to do. So if maybe your cholesterol is high, maybe your doctor's recommended a statin, but you feel a little bit uncertain, For a lot of people, knowing that they already have something in their arteries is enough to motivate them, not just to take the statin, but to do other lifestyle things that maybe they'd been kind of kicking down the road. I'll start exercising next year. I'll start, stop smoking on the new year. So it's a great test to help us see, do you already have evidence of buildup in your arteries? Now, for young women, particularly premenopausal women, rates of coronary calcium are lower, but that doesn't mean you don't have any non-calcified plaque there. So a CAC score of 0 is very reassuring, particularly older in life. But for young women and men, a CAC score of 0 doesn't get you off the hook. So it doesn't mean you can go stop taking your statin or stop exercising. So, there's a little bit of caution and not overemphasizing on the other direction.
Mm-hmm.
And we like to see scores of 0. Any coronary calcium means you're at increased risk of heart attack or stroke because it means there's already cholesterol deposited in your artery walls. But coronary calcium goes up as we age. So what you probably got with your CAC score was a percentile, and that would have told you how much CAC you have compared to other women your age. And I think that can be helpful to sort of guide the gestalt of high or not.
Mm-hmm.
High CAC that we definitely want to lower cholesterol and treat other risk factors is a score of about 300 to 400. But in younger people, like in your 50s and 60s, a score of 100 is also considered high for your age. And considering you've got hopefully 30, 40 years left to live, you want to start treatment then and not wait until later. But even for any of my patients, any coronary calcium at all, particularly in young women who are immediately postmenopausal around that time, I very much will recommend getting on some sort of a cholesterol lowering drug if you have some coronary calcium, because whatever your cholesterol level is, it's too high because it's already starting to stick in your arteries.
Right. Now, is this a test that you think people should get every year, every couple of years?
Great question.
Yeah. How often should someone get this test?
About every 5 years is the current recommendations.
Mm-hmm.
But once you're on cholesterol lowering therapy, we wouldn't repeat it. And the reason for that is because one of the ways that statins work is they help kind of make that non-calcified plaque more stable. So we see calcium scores going up in people who are on statins, but that's because that soft plaque that's at risk of breaking off is becoming calcified and sort of staying in place. So following the CAC score, once we put somebody on a medication, is kind of useless because it's going to go up even if your risk has gone down. But if you haven't gotten, like let's say you get a CAC score of 0, you're 45, you want to kind of defer treatment and then take another look, then 5 years is a pretty reasonable window. And the reason we don't do it every year is because although the radiation dose is low, there is some radiation involved. And it just probably doesn't make sense to do a CT scan every year or starting at 45. I mean, that's a lot of CT scans over a lifetime.
Right. Oh, thank you for that. And my cardiologist had told me the same thing, that when they asked her, when should I get this test again? When she put me on the statin for those two reasons, the 18 CAC score and also the kind of high cholesterol and getting higher. And she said, no, there's no need to have another test. But of course I want one because I want to see what it is, but I won't get it. I'll stop myself. I'll control myself. So what's next in your research? Are there new studies and initiatives that you're working on that will complement this new study coming down the pipeline? I mean, what else should we be looking for? What else are you and your team looking for to help us all really understand our personal risks for heart disease and how we can address those risks for heart disease?
Well, right now, most of my work at UT Southwestern Medical Center is now trying to focus on how do we get more of our patients the therapies that we know work. So for example, some people have coronary calcium. We see it on a CT scan that's done for something else. You go in, you have pneumonia, or they want to rule out a blood clot in your lungs. We can actually pick up the calcium incidentally. So what we're trying to do is find those patients, make sure they're aware of the calcium because they've sort of had a CAC score they didn't even know about. and get those people on therapy. We also, in people with heart attack and stroke, even though we have a bunch of drugs to lower cholesterol and get people into a safe zone, know that a lot, in fact, over half of our patients aren't getting to LDL goals. So my work right now is focused on the quality improvement side and our health system. I'm also leading a large cardiovascular outcomes trial that's being run by Eli Lilly, looking at a medication called lepodisiran, which is an LPA lowering medication. And that trial is just getting off the ground. And I've been able to work with some colleagues, Steve Nissen at the Cleveland Clinic, to get this study going. And so that's the other thing that I'm pretty excited about is, I talked about that LPA cholesterol. We don't have therapies right now to lower it. And I'm happy to be part of one study, but there's several other companies that are also in that space making therapies for something that we haven't been able to treat yet.
Oh, that's very interesting. So that's not treatable at the moment. I should have asked you that earlier when you first brought it up. So right now it's just something that you should be, and your healthcare provider needs to be aware of. And then I guess you want to focus even more on all the other controllable things that are happening.
Exactly. What it does is it tells me that your cholesterol related risk is high. Mm-hmm. We can't treat LPA, but we can lower your risk of heart attack and stroke if your LPA is high by lowering your LDL cholesterol, controlling your blood pressure, using the right types of diabetes medicines if you have diabetes. So there's things we can do to treat your risk, even if we can't treat the LPA. But there's several therapies that are in the pipeline for LPA lowering that we're really excited to see progress on. And I'm honored to be a part of one of those studies.
Oh, that's really exciting. And so I know, of course, you'll be back to talk about that study as well.
Well, I'd be delighted.
For sure. So I always like to repeat information, because you've already talked a bit about lifestyle choices, about your weight and what you eat and exercising, and of course, taking a statin if that's recommended for you, so on and so forth. But I really would love to hear from you. What advice would you give the Age Better audience to, things that they can do today, right now, to really focus on their heart health?
Well, today I would say check to see if you've had a cholesterol test in the last 2 or 3 years. And if you haven't, it's probably time to set up an appointment with your primary care doctor to have that done. And you can ask about getting an ApoB test at the same time to really round out that picture. Today, move more, sit less, exercise more, but even just movement, standing up, walking around during the day is also really, really important. Eat more vegetables, more whole grains, more lean protein, and less added sugars and saturated fats. And then maybe be a little bit less afraid of prescription medications to lower cholesterol. A lot of people I know take vitamins, fish oil, other supplements trying to lower their risk of heart disease. They don't work, but we have prescription medications that we know are very safe. So give them a shot. If your doctor thinks your LDL cholesterol is high, these are therapies that cardiologists almost universally feel really comfortable believing in. We know they prevent heart attacks. If you haven't had a heart attack before, there's a lot you can do to prevent it. And if you've had a heart attack or stroke, there's a lot we can do to keep another one from happening.
Oh, yeah, that's wonderful advice. And also to that, I would add really managing your stress. I mean, we do know that midlife can wreak havoc with your stress levels on so many levels. Life can change drastically with jobs and relationships and your children leaving home and so on, and aging parents. And there's just so much going on. So managing stress, getting enough sleep, I know all of that can really contribute to your heart health as well. So I like to add those in. So you talked about the lifestyle choices that we make. What are your top 3 takeaways from today's conversation? Definitely getting that test. And what about that CAC test? The CAC test, right? I want to make sure you get that in there again so people remember.
Great. So, and before I give you my top 3, I just have to point out, because you mentioned to your audience about all the other people in your lives that you're taking care of, adult children who are gone off to college, partners, aging parents, but take care of yourself too. And I see a lot of women who give 100% to everybody else and run out of space for themselves, women and men. But at midlife, you're getting pulled from both directions in terms of taking care of other people.
Absolutely.
So top 3 take-home points is 1, know your risk of heart disease. And that it means knowing your cholesterol, your ApoB, your blood pressure, your blood sugar, and in the right people, having a coronary artery calcium score to see if you've already started to develop early heart disease. 2 is it's never too late to start healthy habits. So your risk of heart attack and stroke go down almost immediately if you stop smoking today. You can change your diet and you can start exercising today and you will start to accumulate benefits. It's not too late. It's never too late. Even once you've had a heart attack, there's a lot I can do to prevent more disease from happening. And then the third is it's not too early. If you're healthy and you feel great and you don't know that your cholesterol is high, this is actually the right time to go get it checked, because the earlier we start with cardiovascular disease prevention, the more effective our therapies are and the more we can prevent down the line.
Thank you so much for those takeaways. I really appreciate it. I so appreciate everything that you're doing to help us to age better and to help us all focus on our heart health, and all the research that you're doing and your team. Really appreciate it and the time that you spent with us today. Thank you.
Thank you.
Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this: we can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.